So as we all know that chest radiology, forms a very integral part. It is very important. I think that is one investigation that we do every day as a part of our routine investigations in the ICU. And portable chest radiographs is what we do these days. Bedside ultrasound, which is an extremely useful modality, very widely used wherever it is available. And of course, MDCT is reserved for complex cases. So, when we do radiology or when we do X-rays, I'm going to be mostly concentrating on X-rays because we have a session on CT right after my talk. So, when you look at the X-rays in the ICU, they are portable X-rays and it's a AP view that we see. And the major difference is, that the heart would appear enlarged, the scapula would be projected over the lung fields, the clavicles, which would be more horizontal and equidistant. Remember something about the clavicles. A lot of times, if you don't explain it to your technicians and your staff to properly position the patient who are usually lying supine in your ICU, you need to always look for the rotations, which are often common. And of course, image quality these days, although very less common, because we have digital X-rays, has lower resolution, which is not mostly a problem wherever the digital X-rays are available. So you have to be very cautious in your interpretation, and this is basically an AP view. So we're going to look at more AP views as we go ahead. Now, always remember there should be a systematic approach. We've been following systematic approach all throughout this series. We've been talking about the approach. And there's something known as an idea approach, wherein you identify, you describe the lesion, you explain, and you take appropriate actions. So, what do you identify on a chest x ray? First of all, always remember never be in a hurry to look at the x ray. Identify your patient, very important, because a lot of times we have packs and you end up putting in the name, and sometimes it's a different patient. So, why did you do it? What did the patient present with? And what are you looking for in that image? It is very important to remember these aspects and look at your imaging. Now, first of all, when I look at this X-ray, I feel this is not a proper X-ray because I cannot see the costophrenic angles. I cannot see the lung fields. However, it is important to understand what are the mediastinal structures which are seen on an X-ray. So this X-ray, I'm basically going to be showing you the vessels and the structures. So this is your superior vena cava, which is seen like this on an X-ray, although it goes all the way down to the right atrium. This is your ascending aorta. This is your right atrium. Then this is your inferior vena cava. Then, then when you look at, this is the aortic arch, then the pulmonary artery, then the left atrium and the left ventricle. And then, of course, you have the trachea and your main stem bronchi, right and left. Just to show you what we see on a lateral X-ray, although we don't do this in the ICU, but this is to identify the structures. So, this is your descending aorta, this is your aortic arch, then this is your ascending aorta, the right ventricle, and the inferior vena cava. This is how these structures appear. And then this is your left ventricle and the left atrium. Then there are certain spaces, the retrosternal clear space and the retrocardiac clear space. Then, of course, the sulci. So you have your cardiophrenic and your costophrenic angles. So these are your costophrenic angles and your cardiophrenic angles. These are important to know because when you're interpreting a pathology, you need to know where are the normal angle, where are your normal costophrenic and cardiophrenic sulci. Now, ICU is a place wherein you have a lot of hardware, right? Basically, what I mean is your tubes, lines, catheters. And it is very important to know what is the right position of these catheters and when and how to identify when they are malpositioned and to immediately correct them so as to prevent catastrophic events. Also, these days it's mandatory that you have an ultrasound guided placement of your lines and tubes. And in most of the ICUs, I think ultrasound is available these days. So, one of the most commonly placed tube is your nasogastric tube, which runs along the midline course, along the mediastinum, passes the carina, and then it passes the diaphragm also, and it is about 10 centimeters past the gastroesophageal junction. That's where its tip lies. So this is basically a characteristic chest X-ray showing you a correctly placed nasogastric tube. Then if you look at these x-rays, the nasogastric tube is going into the right lower lobe bronchus. Now, this is something that, like I said, it is very important to know the right position and to correctly identify the malposition. So this can lead to, of course, pneumonia. It can cause a lot of problems to your patient, can make your patient hypoxemic suddenly. Patient was fine and, can suddenly develop a respiratory distress if you start feeding without checking the position. So of course you check the position clinically, but X-ray is also important to check the position. Then again, this is again going into the right lower lobe bronchus. Now, this was an elderly gentleman. He's still admitted with us. He actually presented with this X-ray wherein the nasogastric tube was initially placed. As you can see, it is rightly placed. He was not feeding well, very irritable in the ICU. He's a 90 years old male. Now, this patient actually pulled out his tube, which was again tried to, we tried to put it again. And as you can see that it is malposition. One, two, it has caused a pneumothorax. Now, again, this tube, first the chest tube was placed, the pneumothorax is, of course, the lung is expanded. The patient is fine, but now the nasogastric tube has been placed endoscopically. But it is important to remember that complications can occur, and you need to always remember that never be in a hurry to feed your patient or immediately jump on just after you've put in a nasogastric tube, because it can also cause clinically. Of course, we always check after placing, but always do a chest x-ray also to confirm the position. Now, the next common tube that we see in the ICU is the endotracheal tube. Now, endotracheal tube can also, this is again one of the common malpositions that we see, that it goes into the right main stem bronchus and it causes a complete collapse on the left side. The patient is not getting ventilated, it's get desaturating, your ventilator is alarming continuously. Another malposition, endotracheal tube in the right main stem bronchus. Then this was actually an interesting case, not just about malposition. This was actually a long-standing tracheostomy tube of a patient, and this patient actually now presented an encephalopathy, but always, kept coming back with recurrent chest infections. If you look carefully, there is a TT tube, and can you see the cuff being so overly inflated? Also, the trachea is quite dilated in this patient. So actually, she was a case of Munia Kun, and this was her CT of her trachea. If you can see how widely dilated the trachea is. So a long-standing tube can cause complications. This patient had tube for over 2 years actually. Of course, they were changed repeatedly, but it can lead to complications. So you need to, reassess your patients and recheck. There could be other problems which could be causing the patient to present to you the way they are. Now, the commonest lines that we see is your central line. Now, the right internal jugular line, which is the central line which is placed, should be into the SVC, and catheter should be vertically oriented. If it is placed by the right or the left subclavian vein, then into the SVC, and catheter should pass below the level of the clavicle, then it should curve downwards. So the tip should lie at the lower SVC above the cavo-arterial junction. This is a correctly placed central line, also seen on the coronal cut of the CT. Then if you look at this right IJV, it's slightly up, right? This should be repositioned. It should be pushed a little down. This is a right subclavian. It is going into the right atrium. So again, this is a malpositioned tube. It should be pulled up a little. Then again, you can see it's curving out only. So this is another malpositioned central line. Another central line which is malpositioned. So always look at the chest x-ray carefully after inserting your lines and tubes. Then dialysis catheter, which is very similar to the central line. Again, the tip should be the cavo-arterial junction in the right atrium, and these are the tunnel dialysis catheter on the left and the right. Then intercostal drainage tube placement. Now, remember that tubes we generally put in for effusion and pneumothorax. There is something known as a safe triangle wherein the ICD should be put. Then for the pneumothorax, it should be directed upwards and anteriorly. For a pleural effusion, it should be posteriorly and basally. The holes, the eyes of the ICD should be inside the pleural cavity unless you want your patient to develop subcutaneous emphysema and other complications. The tip of the tube should be projected within the pleural cavity. It should not be abutting your mediastinum or diaphragm, and it should obviously not cross the midline. So this is basically a chest tube. This is a little up actually, but this is how it should be placed. There is also some subcutaneous emphysema. And then again, if you look at this, you can see on the chest X-ray, there's a tube. If you appreciate on a coronal cut of a CT, this patient wasn't getting better. And then if you observe, the pneumothorax is actually not complete. The lung is not expanded. It's still there. If you appreciate, the eye is outside. So it is important to have a proper placement of the tube, and these eyes should be within the pleural cavity. They should not come out. This patient also had subcutaneous emphysema, which is not seen. Then another device that we see in the ICU is in the patient is the pacemaker leads, which are placed in the right atrial appendage, the right atrium, the right ventricle apex, as well as the left ventricle. So as you can see, the tip of the atrial lead is pointed upwards, and it's actually on the lateral and over here also. This is upward and anteriorly because the ideal position is actually the right atrial appendage, where it is anchored within the coast trabecular. And the tip of the ventricle lead is positioned in the apex of the right ventricle, and which is located on the left of the spine in the frontal chest X-ray. And as you can see here, it is anteriorly on the lateral view. So these are your pacemaker leads. Then CRT device is another device, which is a biventricular pacemaker with 3 leads. If you can see here, there are CRT device with 3 leads. Then wireless pacemaker device, which has also been used these days, and often you would see a capsule-like device on your chest X-ray, which is your wireless pacemaker device. Then this was a patient post cardiac surgery. And if you look at this patient, there are multiple lines and tubes. Just look at the number of tubes and lines. So you can see the endotracheal tube, you can see the central line, you can see the ECG leads, you can see the Swan-Ganz catheter, you can see the stenotomy wires, the prosthetic valves, then you can see the defibrillator pads, and also the ICD tubes in situ. There are 3 ICDs on both the sides. So many lines and tubes. So this is a patient that you often see in the ICU with so many lines and tubes in situ. So always remember correct position, where should your tip lie, and always should be able to identify the mal position and correct it immediately. Now, there are various pulmonary parenchymal diseases, the lung diseases that we see in ICU patients, like the hydrostatic pulmonary edema, ARDS, pneumonia, aspiration, pulmonary hemorrhage, as well as atelectasis, which is your collapse. So a pneumonia patient would have consolidation. There could be interstitial shadows in your ARDS as well as your pulmonary edema patient. There could be presentation with a nodule mass. There could be atelectasis in patients of collapse. So this is a typical X-ray showing you a hydrostatic pulmonary edema. Another X-ray with pulmonary edema in a female patient. Now, this patient actually came in with this X-ray and, was admitted for a surgery, was kept 10 p.m., started on fluids. And if you observe, overnight, actually, we got a call at around 9 p.m. that he's become suddenly breathless, was a 65-year-old gentleman. And if you observe, he's started to develop pulmonary edema. So you have to be careful. You have to look at the patient profile, understand his requirements, look at the echo if needed in elderly patients, and accordingly decide about your fluids as well. Now, another, this is basically a CT presentation of hydrostatic pulmonary edema. In the initial phases, there is smooth septal thickening on the CT, and ahead as the process of the edema further progresses, you can see ground glassing, you can see fissural effusion, and you can see bilateral pleural effusion. So now this was a patient post cardiac surgery and ventilated and suddenly desaturated. Patient could not be, he was not maintaining his saturation. He was there was a lot of asynchrony, and the patient was uh, there was a lot of alarms on the ventilator that were ringing. So when the X-ray was done, this is how the X-ray appeared, and as you can see, there is presence of pulmonary edema. And as the patient was put on appropriate diuretic therapy and the fluids were reduced, the volumes actually, his intake was appropriately managed. He gradually improved symptomatically, and as you can see, there is a dramatic change on the X-ray as well. And patient was subsequently extubated also post the cardiac surgery. Now, this was actually a patient of CKD and uric and presented with acute onset shortness of breath. And you can see there's presence of pulmonary edema. And post dialysis, the x ray got better. The patient actually was symptomatically better, which was the most important aspect. So, remember that pulmonary edema can, of course, be cardiogenic as well as non cardiogenic. You need to always remember the etiology and appropriately treat the etiology every time you have a patient of pulmonary edema. And so, you would find improvement in your patient. So, now the next entity that we are going to look at is your ARDS. Now, this was a patient with right lower lobe pneumonia presented in respiratory failure with a PF ratio of less than 100, was intubated, as you can see in this X-ray. Subsequently, in the less than 12 hours, developed bilateral bronchopneumonia, worsening shadows, and was patient. Of course, the ventilation strategy was subsequently modified, and the patient was managed as per the ARDS ventilation strategy. And this X-ray was about 10 days later with the reticular nodular shadows bilaterally in the fibroproliferative phase of the ARDS. So, these are different presentations of a patient with acute and then sudden worsening, and then in the fibroproliferative phase of your ARDS. Then this is just to show you that in these ARDS patients we also put them on ECMO, and this is the placement of the ECMO catheters, the right IJ, which is your reinfusion catheter, and the draining catheter, which is in your right femoral. The distance between them should be minimum 12 to 15 centimeters. So this is just an X-ray showing you another form of lines that you see, which is your ECMO catheters. So when you differentiate between the hydrostatic pulmonary edema and an ARDS X-ray, the heart size is usually increased in a patient with pulmonary edema. ARDS, it would be normal. Distribution of opacities would be central and even symmetric in pulmonary edema, whereas in ARDS, that would be peripheral, patchy, and often asymmetric. Pleural effusion is very common. We've just seen the X-rays, and it's not common in ARDS patients. Now, pneumonia and mechanical ventilation and aspiration are two main risk factors for pneumonia in ICU. And about 24% of patients after 2 days of ventilation are at a risk of developing ventilator-associated pneumonia. But always remember that when you have a patient with shadows which look like pneumonia, always rule out consolidation, rule out the non-infectious causes of pneumonia. Don't be in a hurry to investigate or start treating your patient, because there can be other causes which look like that, and you should always rule them out. So this was a patient with right lower lobe consolidation with effusion, and you can see this on the CT also. There's a large consolidation with effusion. Then this is X-ray showing you bilateral bronchopneumonia. Now, these days in ICUs, we have a lot of immunocompromised patients. We have a lot of post-transplant patients, and these patients are prone to opportunistic infections. So, the common opportunistic infections that we see are with your pneumocystis jirovecii, cytomegalovirus infections. There can be also atypical infections. There can be other opportunistic infections. So you have to remember that most of these infections are, you cannot. Now, this was an X-ray of a patient who had bilateral infiltrates, was an immunocompromised post-transplant patient. And his samples were sent. Initially, he presented with fever, and his samples were sent, and his initial cultures were negative, but his PCP and CMV PCR came positive, and he was treated for both and got better. So pneumocystis jirovecii can present with diffuse ground glassing on both the sides. There can be presence of pneumatoceles. There can be presence of air bronchograms. And cytomegalovirus can have, again, bilateral ground glassing, nodular shadows. So varied presentations of both, but the diagnosis of these is dependent on microbiology. If it is possible, the best way is to obtain a good respiratory sample, preferably by doing a bronchoscopy and taking a BAL. Now, another entity that we often see in the ICU is your collapse and atelectasis. And, when this happens, generally there is, because there's presence of a lot of secretions, there is There are mucus plugs that block your tubes. There can also be a lot of clots if the patient has an underlying condition which is making him prone to bleeding or for any other reason. So these are the common reasons why you would see collapse in the ICU. So these are your X-rays showing you right upper lobe collapse. Then this is a X-ray typically showing your right middle lobe collapse. Then this is a right lower lobe collapse, which is also called the SAIL sign on the X-ray in cases of right lower lobe collapse. Then this is an X-ray showing you a left upper lobe collapse. So you need to be able to identify the reason and appropriately address the reason. If there's a clot, if the patient is intubated, if the tube is blocked, you need to change it. You need to suction properly. Make sure your secretions are removed properly. And in cases, such a patient, you would often get a call that the patient is suddenly desaturated, is not breathing properly, and there is, problem, is having a lot of breathing difficulty, and there would be you would do an X-ray and you would find a linear atelectasis like this. So, proper chest physiotherapy, incentive spirometry, and these are the kind of things that generally help these patients get better. You generally don't have to do anything major, but you have to make sure that there is a proper physiotherapy and other things that are done. Now, if you look at this X-ray, you see the endotracheal tube going beyond the right main bronchus. So it has basically collapsed the complete left lung as well as the right upper lobe also in this case. So this is just another uh, presentation of collapse. Now, is this an effusion or a collapse? If you see the mediastinum, it is pushed completely to the left side. So this is basically an X-ray of an effusion. So pleural effusion can present in various ways, and we'll just look at, there can be subpulmonic effusion, there can be a loculated effusion, there would be blunting of costophrenic angles, there could be a meniscus sign, there could be a laminar effusion, there could be a complete opaque hemithorax, and you might see air fluid levels in case of hydropneumothorax also. So for a blunting of a costophrenic angle in an AP film, you need about 200 to 300 ml of fluid. And for on a lateral film, about 100 to 150 ml blunts your posterior angle on a less lateral chest X-ray. Now, as you can see, these are three different X-rays showing you this is a large left pleural effusion. There is again presence of effusion over here, and then it can also be in the fissures. And then sometimes loculated effusion appears like this. So this is an X-ray of a loculated effusion. Now, subpulmonic effusion is the fluid which is present between at the base between the lung and the diaphragm. So it basically raises your diaphragm, becomes more tented. Sorry. And usually about less than 50 ml of volume is needed. So different presentations. Now, in supine that we usually do in an ICU, the X-ray for an effusion can appear like this. There can be lack of air bronchograms and preserved vascular markings. So sometimes it is very difficult to, pinpoint. So in these cases, because we have ultrasound, you should quickly put your bedside ultrasound and check for effusion and take appropriate action. Again, different X-rays showing you right and left massive effusions. Then on ultrasound, effusion appears like this. This is a simple effusion, and this is, a loculated effusion, chronic effusion. Now, this was an interesting case of a 70-year-old female who presented, with fever and septic shock. Now, initially, this patient did get better with antibiotics, but the TLCs continued to rise, and the patient started having pain in the right hypochondrium. Now, you know, this was the ultrasound of the patient. If you can see, is showing you the presence of a liver abscess. Actually, remember that when you have an X-ray presentation like this, or if you have a patient presenting like this, and it looks like an effusion initially, always go back to your history first, which is very important. Then a typical pain in the right hypochondrium, which is persisting with a patient in sepsis like this, with such high counts, remember to always look for a liver abscess, because that is also another presentation which can look like this. This was the CT of the same patient, and I'll just show you. You can see there is a liver abscess which was there, and I'm sorry. And then the drain was put and the patient got better. So remember that if there is a presentation like this, it could be not just an effusion. Don't keep your mind focused on one thing. Always go back to your history, look at the presentation, correlate clinically, and then rule out appropriately with investigations that is required. Now, another entity that we see is pneumothorax, and you know that on a chest X-ray, you have to look for absent vascular markings, and of course, expiratory film can enhance it, but in ICU, it's difficult. Um, in because we do supine X-rays, so air can accumulate in posterior costophrenic sulcus, and it may appear as a deep sulcus sign, which we often see in the ICU. And it can be easily missed on an inspiratory erect view. So if you're not seeing your X-ray carefully, you might just miss out this deep sulcus sign. So this was a patient you can see with right pneumothorax, another right pneumothorax. ICD was put in. There is presence of subcutaneous emphysema in this patient on both the sides. Then this was a tension pneumothorax, as you can see. There was a patient suddenly who, the nurse called that had a sudden cardiac arrest. CPR was initiated, of course, and the patient was revived. We put in a needle in the second intercostal space initially because it was pneumothorax was actually thought of as because there was absence of air entry on the left side. And when we did the X-ray, this is how the X-ray appeared. So after the patient was revived, immediately a chest tube was put. Now remember that when once you put in a chest tube, it is possible that your lung does not expand. Why? Because it has been falsely placed in a false track. It can go in your subcutaneous plane, which you cannot really delineate on a chest X-ray. Also, maybe the tube is blocked. If there's some clot, there's blood, there's secretions, anything which can clot your chest tube. So the easiest way to quickly, do it is basically put in another chest tube and the lung will expand. And then, subsequently you can appropriately address the first tube if needed or just leave it in there for that timing till the patient is completely settled. So now since we do most of the x-rays in supine position, you see that the air would not appear in the apex, the pneumothorax, right? So these are the areas where you would see your air in supine position. And like I said, if you look at an erect film, you would miss out. So you see a deep sulcus sign here. Remember, it is important to look at your patients. Always have a systematic approach. Always look at your cardiophrenic and costophrenic angles. So this is basically an X-ray showing your deep sulcus sign. Another X-ray with deep sulcus sign, if you can see here on the left. So now this patient actually, developed pneumothorax because the chest tube got blocked. So, sorry, subcutaneous emphysema because the chest tube got the patient actually had an ICD for pneumothorax. And once the lung had expanded, suddenly, there was crepitus in his chest wall, and he also developed this subcutaneous emphysema, which can be seen on the chest X-ray. His tube was blocked. So, appropriate action: you flush the tube, you check the bag, you inspect the tube, and once the tube blockage is relieved, the lung would expand and the subcutaneous emphysema would also get better. Now, there can be presence of fluid along with air, and there would be this characteristic air fluid level that would be seen, which is your, sorry, hydropneumothorax. Now, is this a pneumothorax? We have a lot of elderly patients in the ICU, right? And a lot of times, suddenly, with no underlying possibility of a patient developing a pneumothorax, this sort of an X-ray picture comes in front of you in the morning. So remember that elderly patients can have skin folds, which can look like this. The repeat X-ray subsequently did not have this air, which you see here. So this was actually not a pneumothorax, but a skin fold. So always examine your patient clinically just by looking at the X-ray. Don't jump onto the conclusion that the patient has developed pneumothorax. Of course, with an underlying history, there can be a possibility always, but always correlate clinically. Now, in pneumothorax, something which is very widely used and very important, and we do it all the time, is your ultrasonography, bedside ultrasound that we use because you can quickly rule out if you have a patient like this with a skin fold. You would do a repeat X-ray and you would wait for that. But when you have an X-ray like this, quickly look with your ultrasound, and you would, if there is a pneumothorax, then you would have absence of lung sliding, absence of lung pulse. If a single B line is present, then there is no pneumothorax. Remember that. Because these are artifacts, A lines, B lines. A lines can be seen. So, this is pneumothorax, as you can see, that there is no lung sliding. And I'll show you another one, which is basically one side is moving and the other is not. So this is your basically your lung point and the characteristic stratosphere sign that we talk about. So pneumothorax bedside, very quickly identifiable with an ultrasound. If you have a doubt, quickly put your ultrasound probe and rule it out. And if there is a pneumothorax present, immediately put in an ICD tube. Another entity that we see in the ICU patients because they are on positive pressure ventilation is your pneumomediastinum. There are various sources of air which are intrathoracic and extrathoracic, and various signs of pneumomediastinum which can be seen on the chest X-ray. So I'll quickly show you some of these signs. As you can see here, because of the presence of air, there's a continuous diaphragm sign on the chest X-ray. Then a loosened band of gas extending along the descending aorta, and intersecting band of gas that extends along the medial left hemidiaphragm, together forming this V, if you can appreciate it. So this is your Nalserios V sign. Again, a sign of pneumomediastinum. Then air on both sides of the bronchial wall, if you can appreciate in this. This is your double bronchial wall sign. It's fully visible on both the sides. Then air around the pulmonary artery, which is called the ring around the artery sign. Then air around the heart, showing you the pneumopericardium. So these are X-rays of a patient who actually presented to us in the emergency with hypercarbic respiratory failure, did not respond to NIV, then had a cardiac arrest, was revived, CPR was done, he was intubated, eventually extubated. He was doing fairly well in the ICU and then suddenly deteriorated again. And there was respiratory distress, he was desaturating. So this is actually his X-ray initially, and this is his X-ray from yesterday. And after doing the X-ray, we systematically examined it, and we could not really see the difference initially. Then we again went back, re-examined the patient. We checked his oral cavity as well, and there were no teeth. And we asked the family about his dentures or did he have any teeth. And the family told us that he had one tooth actually, which was there, and which was now not there in his mouth. And if you look here, you can appreciate this foreign body. So we did a bronchoscopy, and with the SNAR, we removed this tooth. So, this sort of a presentation can also occur in your ICU. The patient is doing well, and suddenly this could have happened during his arrest when he was intubated. He would have lost this tooth and could have gone down, but initially he was on the ventilator. So this sort of a problem can occur. So remember, always, like I said, go back, correlate clinically, re-examine your patient, because that sometimes completely changes your perspective and helps you to reach a diagnosis. And this was removed with bronchoscopic guided with a SNAR. So to conclude, imaging in ICU is an integral part for diagnosing, for monitoring, as well as for guiding interventions. Portable chest X-ray remain the first line modality despite its limitations. Ultrasound provides bedside dynamic and radiation-free assessment of pleura, lung, as well as for securing your lines, as well as putting in your tubes. Multi-detector CT is reserved for complex and unresolved cases, and always remember, for a CT, your patient should be stable to shift. So that is another important aspect. Now, for tubes, lines, and common pathologies, radiology is crucial for detecting malposition and complications of endotracheal tubes, central lines, feeding tubes, as well as chest drains. Common pulmonary conditions that we see is your hydrostatic pulmonary edema, as well as ARDS, pneumonia, aspiration, atelectasis, pleural effusions, pneumothorax, pulmonary hemorrhage, as well as embolism. Always have a systematic approach, systematic review. check the patient ID. Do not forget that ever. Look at the tubes and lines. Look at your lung parenchyma, your patient's on the X-ray, mediastinum, pleura, bones, and soft tissue structures. Compare with the prior films. Integrate with clinical data and answer the clinical questions. Recognize life-threatening findings early, like tension pneumothorax, misplaced tube, massive effusion, and ARDS. Radiology in ICU is not just diagnosis, it guides immediate action and improves patient outcomes. Thank you.